Good morning, everyone. I'm David Patrician, one of the PGY3 psychiatry residents from the University of Saskatchewan. Today I thought it would be useful to go over the schizophrenia spectrum and other psychotic disorders chapter from the DSM-5-TR. I expect this presentation will take between 75 to 95 minutes to complete. These are the objectives for today's presentation. I won't read them in entirety, but what I hope you'll be able to do by the end of this presentation is note the essential features, epidemiology, differential diagnoses, and common treatments for each of the disorders we review. I hope to accomplish this goal by running through a total of 9 clinical cases, all of which are fictitious. Now for case 1. John is a 38-year-old male referred to you with the chief concern of insomnia. He arrives to your office on time and is neatly dressed in a suit and tie, easily engaged with reactive affect, and speaks with a Jamaican accent. He explains that he has been struggling with initial and middle insomnia for the past 3 months, and is worried that daytime sleepiness is interfering with his work as a realtor. In probing for the presence of stressors, you learn that over the same time period, he has grown increasingly convinced that his wife has been cheating on him with an ex-client of his, whom the couple went to dinner with prior to the onset of his sleep difficulties. "I know she's up to something, Doc," he tells you. "I came home from work yesterday and she was baking carrot cake muffins, something she doesn't normally do. And I remember that my client had ordered carrot cake for dessert when we went to dinner. That can't be a coincidence." As you proceed with data gathering, John tells you that he's been seeing his ex-client's car, a white Ford Crown Victoria, almost every day since they had dinner, and he swears that he has smelled his ex-client's cologne upon waking up in the middle of the night, at least 3 times per week for the past month. "Doc, it's like they're taunting me. I haven't brought it up with my wife, and I'm worried what will happen if I do." He continues to attend work and manage his daughter's youth soccer team. Keeping in mind this is a presentation on SSOPD, what is your preferred diagnosis? This is the diagnosis of delusional disorder, the essential feature of which is the presence of 1 or more delusions that persists for at least 1 month. A key feature separating delusional disorder from other diagnoses in this chapter is the fact that social and occupational functioning are relatively preserved. There are several different subtypes of delusional disorder, and they can be remembered with the mnemonic JPEG-SUM. This stands for jealous, persecutory, erotomanic, grandiose, somatic, unspecified, and multiple. Now back to case 1. You establish a therapeutic relationship with John and learn that his uncle struggled with a diagnosis of schizophrenia throughout his life before dying of suicide when he was 58 years old. John is reassured that he does not meet criteria for schizophrenia, but still finds it hard to believe that his wife is not cheating on him with his ex-client. You introduce the concept of delusional disorder, and he has some additional follow-up questions regarding the nature of this condition. What is the lifetime prevalence of this disorder? What is the mean age of onset? Are males more often affected than females? What is the most common type? What is the likelihood that John will go on to develop schizophrenia, like his uncle before him? Regarding the epidemiology of delusional disorder, the lifetime prevalence is 0.2%, with most cases beginning in the late 30s. Significantly more males receive the diagnosis of delusional disorder, jealous subtype, compared to females. But overall, males and females are equally afflicted by delusional disorder, most commonly with persecutory subtype. In terms of risk factors, DSM-5-TR notes a familial relationship with schizophrenia and schizotypal PD, while KNS notes fear of the unknown and adjustment to immigration. You see John in follow-up, and he has continued to struggle with a diagnosis of delusional disorder jealous subtype. He asks you to walk him through the diagnosis once more and clarify why the symptoms and signs seen in his case do not make you think of another mental disorder. What is a differential diagnosis for delusional disorder in general? This is the differential diagnosis for delusional disorder. Let's now take each of these in turn. First up is obsessive-compulsive and related disorders. If an individual with obsessive-compulsive disorder is completely convinced that his or her obsessive-compulsive disorder beliefs are true, then the diagnosis of obsessive-compulsive disorder with absent insight and delusional beliefs should be given rather than a diagnosis of delusional disorder. Similarly, if an individual with body dysmorphic disorder is completely convinced that his or her body dysmorphic disorder beliefs are true, then the diagnosis of body dysmorphic disorder with absent insight, delusional beliefs should be given rather than a diagnosis of delusional disorder. Next, let's differentiate delusional disorder from delirium, major neurocognitive disorder, and psychotic disorder due to another medical condition. Delusions occur in 15 to 50% of individuals with dementia at some point in illness course across all types. Individuals with these disorders may present with symptoms that suggest delusional disorder. For example, simple persecutory delusions in the context of major neurocognitive disorder will be diagnosed as major neurocognitive disorder with behavioral disturbances. In delirium or psychotic disorder due to another medical condition, there is evidence of a physiological link between the general medical condition and symptoms of psychosis, as well as other differentiating factors, including level of functional impairment. Next, we'll see how delusional disorder differs from substance and medication-induced psychotic disorder. A substance and medication-induced psychotic disorder cross-sectionally may be identical in symptomatology to delusional disorder, but can be distinguished by the chronological relationship of substance use to the onset and remission of the delusional beliefs. How does delusional disorder compare to schizophrenia and schizophreniform disorder? Delusional disorder can be distinguished from schizophrenia and schizophreniform disorder by the absence of other characteristic symptoms of the active phase of schizophrenia. Furthermore, the quality of delusions can help distinguish between schizophrenia and delusional disorder. In schizophrenia, delusions show greater disorganization. That is, the degree to which delusions are internally consistent, logical, and systematized. Whereas in delusional disorder, they show greater conviction. That is, the degree to which the individual is convinced of the reality of the delusion. Greater extension, the degree to which the delusion involves various areas of the individual's life, and greater pressure, the degree to which the individual is preoccupied and concerned with the delusion. And finally, how does delusional disorder differ from depressive and bipolar disorders, as well as schizoaffective disorder? These disorders may be distinguished from delusional disorder by the temporal relationship between the mood disturbance and the delusions, and by the severity of the mood symptoms. If delusions occur exclusively during mood episodes, the diagnosis is major depressive or bipolar disorder with psychotic features. Mood symptoms that meet full criteria for a mood episode can be superimposed on delusional disorder. Delusional disorder can be diagnosed only if the total duration of all mood episodes remains brief relative to the total duration of the delusional disturbance. If not, then a diagnosis of other specified or unspecified schizophrenia spectrum and other psychotic disorder accompanied by other specified depressive disorder, unspecified depressive disorder, other specified bipolar and related disorder, or unspecified bipolar and related disorder is appropriate. John remains hesitant regarding this diagnosis and tells you, "If I see that man again, I'm going to kill him. He's destroying my family and he needs to die." He's clearly angry, and you feel that he is likely to act on his homicidal ideation. He has the ex-client's contact information as well as their home address. With safety in mind, how will you proceed with treatment acutely and in the long term? As with any patient interaction, the most important thing is determining whether or not the patient is at risk of harming themselves or of harming someone else. The therapeutic relationship is always important, but in delusional disorder it becomes a key component of your treatment plan. Patients with delusional disorder often see themselves as discriminated against and not believed. They may present as angry, hostile, and uncooperative. The patient may feel their concerns are invalidated, and meeting a clinician may only lessen their willingness to engage in treatment. Lack of insight and trust complicate matters further. Thus, initial encounters may be awkward and even tense, and the patient may reject psychiatric treatment initially. In response, the clinician should listen and empathize with the patient's distress. This approach and considerable diplomacy are required to establish the relationship. Steadiness and patience are also essential to make an alliance possible. Clinicians may be able to engage patients by clarifying that the therapeutic objective is to relieve the unpleasant preoccupations and isolation that are associated with responding to delusional concerns rather than eliminate the delusion. Identification of co-occurring psychiatric disorders may also help the clinician engage a patient with delusional disorder, as the patient is more likely to discuss and receive treatment for anxiety or depression rather than for the delusion. If the comorbidity can be effectively managed, the patient may be inclined to participate in treatment for the delusion. Pharmacotherapy can also be used, but needs to be approached carefully. Recommendations include the use of a second-generation antipsychotic, and if adherence problems are encountered, a long-acting injectable medication can be considered. In the event of treatment resistance or symptoms of depression with risk of suicide, clozapine can be considered. Other options include olanzapine and risperidone. Adjunctive psychotherapy with CBT and supportive psychotherapy also has evidence in the treatment of delusional disorder and can be a good adjunct in addition to medication. Now let's conclude Case 1. John was safely transferred to the University Hospital, assessed by the emergency department psychiatrist, and admitted under certification. Fortunately, he responded well to the second-generation antipsychotic he recommended. Unfortunately, he no longer wishes to attend your clinic and has asked to be transferred to a different psychiatrist. Years later, you see an article in the local newspaper celebrating his tenure as the city's most productive realtor. The article includes a picture of his wife and daughter, who are smiling and hugging him from either side whilst he lifts a large gold trophy into the air. Now on to Case 2. You were a fourth-year psychiatry resident on call on New Year's Day, and you've been asked to assess Brianne Anderson, a 35-year-old female, with the reason for referral being psychosis. Reviewing the electronic health record, you see that Brianne was admitted to the inpatient unit 3 years ago with psychosis, with precipitants including the death of her mother and losing her job as a laboratory technician. The resident working with her at that time had documented several personality traits, including perceptual dysregulation and suspiciousness. She improved over the course of 1 week with risperidone and supportive therapy, and the total duration of illness was 3 weeks from start to finish. On assessment, Brianne is overtly paranoid and perseverates. She refuses to sit down and repeatedly asks that the interview room door be left open so that she can see out into the hallway. It is a fruitless interview. You contact her fiancé and acquire the following collateral history. On Christmas Eve, Brianne's home was broken into while she was out partying, and her mother's diamond necklace was stolen. Since then, Brianne has been sleeping poorly and pacing during waking hours. Eventually, she even started accusing me of having stolen the necklace. I know it meant a lot to her, but she's gone a little far with this. Today, she was threatening me and holding a knife. I called the police, who were able to calm her down and take her to the hospital. I don't understand what's happening with her. Before the robbery, she seemed fine. Keeping in mind that this is a presentation on SSOPD, what is your preferred diagnosis? This is brief psychotic disorder, the essential feature of which is a disturbance involving at least one positive psychotic symptom or grossly abnormal psychomotor behavior or catatonia. As you can see in the abbreviated DSM-5-TR criteria, negative symptoms don't count. The total length of illness is from 1 day to 1 month, followed by a return to function. Specifiers that can be applied in the case of brief psychotic disorder include with marked stressors, without marked stressors, with postpartum onset, and with catatonia. Brianne gradually settles into the inpatient unit and symptoms remit. She responds well to your treatment of choice, and on the day of discharge you meet with her and her fiancé to review course in hospital and plans for follow-up as she transitions back into the community. The couple have several questions for you. What is the lifetime prevalence of brief psychotic disorder? What percentage of first episode psychosis are accounted for by brief psychotic disorder? What is the mean age of onset? Are males more often affected than females? What is the rate of relapse for patients diagnosed with brief psychotic disorder? Are there personality variables that increase the chance of someone developing this disorder? What is the chance that Brianne will go on to develop schizophrenia? According to DSM-5-TR, brief psychotic disorder accounts for 2 to 7% of cases of first episode psychosis and has an average age of onset in the mid-30s. Females with a diagnosis of brief psychotic disorder outnumber males at a ratio of 2 to 1. According to DSM-5-TR, risk factors include pre-existing schizotypal and borderline PD, as well as traits in psychoticism and negative affectivity domains. K&S notes deficient ego strength as a risk factor and explains that brief psychotic disorder occurs as a response to intense, emotionally stressful events, which in the absence of a supportive environment, overwhelm the individual's defense mechanisms. The rate of relapse is fairly high at more than 50%. but the likelihood of an individual progressing to another SSOPD, like schizophreniform disorder or schizophrenia, is less than 50%. You reconnect with Brianne and her fiancé in outpatient clinic several months following discharge from hospital. Brianne remains stable on your selected treatment, and there is no evidence of psychotic symptoms, positive or negative. Her fiancé, understandably nervous after having been threatened with a knife and accused of theft, asks you whether there are any other explanations for what might have caused her behavior on New Year's Day. What is the differential diagnosis for brief psychotic disorder in general? This is the differential diagnosis for brief psychotic disorder. First, let's consider other medical conditions. A variety of medical conditions can manifest with psychotic symptoms of short duration. Psychotic disorder due to another medical condition or a delirium is diagnosed when there is evidence from history, physical exam, or laboratory tests that the delusions or hallucinations are the direct physiological consequence of a specific medical condition. How does brief psychotic disorder differ from substance-related disorders? Substance and medication-induced psychotic disorder, substance-induced delirium, and substance intoxication are distinguished from brief psychotic disorder by the fact that a substance, such as a drug of abuse, a medication, or exposure to a toxin, is judged to be etiologically related to the psychotic symptom. Laboratory tests such as a urine drug screen or a blood alcohol level may be helpful in making this determination, as may a careful history of substance use with attention to temporal relationships between substance intake and onset of the symptoms and to the nature of the substance being used. Next, let's differentiate between brief psychotic disorder and depressive and bipolar disorders. The diagnosis of brief psychotic disorder cannot be made if the psychotic symptoms are better explained by a mood episode. That is, the psychotic symptoms occur exclusively during a full major depressive, manic, or mixed episode. How does brief psychotic disorder differ from other psychotic disorders? If the psychotic symptoms persist for 1 month or longer, the diagnosis is either schizophreniform disorder, delusional disorder, depressive disorder with psychotic features, bipolar disorder with psychotic features, or other specified or unspecified schizophrenia spectrum and other psychotic disorder, depending on the other symptoms in the presentation. The differential diagnosis between brief psychotic disorder and schizophreniform disorder is difficult when the psychotic symptoms have remitted before 1 month in response to successful treatment with medication. Careful attention should be given to the possibility that recurrent disorder, such as bipolar disorder or recurrent acute exacerbations of schizophrenia, may be responsible for any recurring psychotic episodes. It is important to distinguish between brief psychotic disorder and malingering and factitious disorder. An episode of factitious disorder with predominantly psychological signs and symptoms may have the appearance of brief psychotic disorder, but in such cases there is evidence that the symptoms are intentionally produced. When malingering involves apparently psychotic symptoms, there is usually evidence that the illness is being feigned for an understandable goal. Lastly, we'll differentiate between brief psychotic disorder and personality disorders. In certain individuals with personality disorders, psychosocial stressors may precipitate brief periods of psychotic symptoms. These symptoms are usually transient and do not warrant a separate diagnosis. If psychotic symptoms persist for at least 1 day, an additional diagnosis of brief psychotic disorder may be appropriate. Some time passes, and you are teaching a lecture series on schizophrenia spectrum and other psychotic disorders. One of the medical students in the audience asks you how you approach treatment in Brianna's case. With safety in mind, how would you proceed with treatment acutely and in the long term for someone presenting with brief psychotic disorder? As with delusional disorder, management of brief psychotic disorder is based on the individual's ability to maintain safety, which you can determine based on direct questioning about homicidal and suicidal ideation, and how well you believe they will be able to meet their basic needs. Medication choices should be based on presenting symptoms and comorbidities, with consideration for the different side effect profiles for each medication. The approach to individuals with brief psychotic disorder is the same as the general initial management plan of psychosis, regardless of the cause. This includes antipsychotic medications and adjunctive supportive therapy. Some patients with severe anxiety and agitation also warrant adjunctive treatment with short-acting benzodiazepines. Unfortunately, there are no clinical trials or case series examining the efficacy of treatments for brief psychotic disorder. And now to conclude Case 2. Brianne continues to attend outpatient appointments with you for 2 years before being successfully weaned off of antipsychotic medications. You never see her again, but feel assured that she has a supportive husband, a career that she loves, and will continue to follow up with her outpatient therapist in the community for the purposes of supportive psychotherapy. Now Case 3. You're a medical student participating in the adult inpatient portion of your psychiatry rotation. You've been asked to meet with a 24-year-old patient named Doug and his wife Janice. You've been told that Doug was admitted last night with the chief concern of anxiety, but unfortunately, one of the nursing students seems to have walked away with Doug's chart, so you're unable to review the admission note prior to introducing yourself to the couple. On interview, Doug bounces his leg up and down and nervously bites his nails. He fails to make eye contact with you, instead staring down towards the floor. Janice tries to calm him, but this has no effect on his mental status. He repeats the phrases, "What's going on?" and "I just don't get it," frequently throughout the interview. Unable to engage Doug in conversation, you turn to Janice, who explains that 2 months ago, her husband was doing just fine. Janice tells you, 2 months ago, he was going to work and meeting with friends on the weekend, just like he always had. Initially, I thought he was worried about something going on at work. I noticed he wasn't sleeping as well as he usually did, and he was keeping to himself more, which is very unusual for him. Things really came to a head yesterday afternoon when I got back from work. To my horror, I found him in the garage sitting in an upturned bucket with a shotgun in his hand, rocking back and forth and talking to himself. Thankfully, the shotgun wasn't loaded, but I knew he needed to get to the hospital, so I called 911. I'm really worried. Nothing like this has ever happened before. It reminds me of my nephew who has schizophrenia. Do you think that's what we're dealing with? Keeping in mind this is a presentation on SSOPD, what is the most likely diagnosis in this case? Are there any specifiers unique to this diagnosis that you could apply? This is a case of schizophreniform disorder. As we'll soon see, schizophreniform disorder is essentially the same as schizophrenia, except that it lasts for 1 to 6 months. The unique specifiers belonging to the diagnosis of schizophreniform disorder are with good prognostic features and without good prognostic features. In order to receive the good prognostic features specifier, 2 of the following must be present. Number 1. Onset of psychotic symptoms within 4 weeks of the first observable change in behavior. Number 2. Confusion or perplexity. Number 3. Good premorbid social and occupational functioning. And number 4. Absence of blunt or flat affect. These can be remembered with the following mnemonic story. Doug is a confused but euthymic man who was functioning well, then behavior changed. Then within 4 weeks he developed psychosis. You report back to your attending psychiatrist and explain your rationale for selecting schizophreniform disorder as a preferred diagnosis. They thank you for seeing Doug and agree with your clinical assessment and diagnosis. Impressed with your proficiency, they decide to quiz you on the epidemiology of schizophreniform disorder and pose the following questions. What is the lifetime prevalence of schizophreniform disorder? What is the worldwide incidence of schizophreniform disorder? Is schizophreniform disorder more common in lower or higher income countries? Which is more common, schizophreniform disorder or schizophrenia? What proportion of patients with schizophreniform disorder transition to schizophrenia? What is the recovery rate for schizophreniform disorder? Incidence of schizophreniform disorder across sociocultural settings is likely similar to that observed in schizophrenia. In the United States and other high-income countries, the incidence is low, possibly 5-fold less than that of schizophrenia. In lower-income countries, the incidence may be higher, especially for the specifier with good prognostic features. In some of these settings, schizophreniform disorder may be as common as schizophrenia. The development of schizophreniform disorder is similar to that of schizophrenia. About 1/3 of individuals with an initial diagnosis of schizophreniform disorder, provisional, recover within the 6-month period, and schizophreniform disorder is their final diagnosis. The majority of the remaining 2/3 of individuals will eventually receive a diagnosis of schizophrenia or schizoaffective disorder. According to DSM-5-TR, relatives of individuals with schizophreniform disorder have an increased risk of developing schizophrenia. K&S notes the difficulty in distinguishing risk factors for schizophreniform disorder from those of schizophrenia, as the data are frequently combined. They also note a number of anatomical findings in which individuals with schizophreniform disorder may differ from controls. However, results from these studies have been mixed and are difficult to interpret. Having flexed your oddly detailed knowledge of the epidemiological underpinnings of schizophreniform disorder, you decide to impress your attending even further by wading through the differential diagnosis of this condition. What is the differential diagnosis for schizophreniform disorder in general? This is the differential diagnosis for schizophreniform disorder. First, let's consider other mental disorders and medical conditions. A wide variety of mental disorders and medical conditions can manifest with psychotic symptoms that must be considered in the differential diagnosis of schizophreniform disorder. These include psychotic disorder due to another medical condition or its treatment, delirium or major neurocognitive disorder, substance and medication-induced psychotic disorder or delirium, major depressive or bipolar disorder with psychotic features, schizoaffective disorder, other specified or unspecified bipolar and related disorder, major depressive or bipolar disorder with catatonic features, schizophrenia, delusional disorder, other specified or unspecified schizophrenia spectrum and other psychotic disorder, schizotypal, schizoid, or paranoid personality disorders, autism spectrum disorder, disorders presenting in childhood with disorganized speech, ADHD, obsessive compulsive disorder, PTSD, and traumatic brain injury. Since the diagnostic criteria for schizophreniform disorder and schizophrenia differ primarily in duration of illness, the discussion of the differential diagnosis of schizophrenia also applies to schizophreniform disorder. How does schizophreniform disorder differ from brief psychotic disorder? Here the difference is timing. Symptoms last for less than 1 month in brief psychotic disorder and at least 1 month in schizophreniform disorder. Excellent, just excellent, exclaims your attending, clearly elated by your knowledge of this disorder. Now tell me, they say, moving their chair closer to yours. How would you approach management of this patient's disorder in both the acute and long term? With safety in mind, how would you proceed with treatment acutely and in the long term for someone presenting with schizophreniform disorder? The approach to individuals with schizophreniform disorder is the same as the general initial management of psychosis regardless of its cause. This includes antipsychotic medications and adjunctive supportive therapy. It's important to remember that while second generations and first generations antipsychotics are equal in efficacy, they are not the same in terms of adverse effects, and this must be considered individually depending on your patient. There is evidence for supportive psychotherapy as well as CBT for psychosis. Psychoeducation is a mainstay of treatment for schizophreniform disorder, not just for the patient, but for their family and community as well. Here's our conclusion. It is the end of your adult inpatient psychiatry rotation, and your preceptor bids you a fond farewell by completing your outstanding EPAs. Although they are dismayed that you prefer a career in family medicine over psychiatry, they take solace knowing that your proficiency in psychiatry will be an asset to your future patients. You are the child and adolescent psychiatrist on call when one of the emerge docs refers a 15-year-old male patient for the assessment of depression. The following history is relayed to you. Please review this 15-year-old patient named Jeremiah Smith. Jeremiah lives with his biological parents, mom age 34 and dad age 73, and younger sister age 4. He was born in the city and raised there until he was age 6 when he moved to the small town. Perinatal history is significant for gestational diabetes and exposure to maternal stress. Breech delivery and hypoxia due to entanglement with a nuchal cord. 1-minute APGAR scores were low, but 5-minute APGAR was much better. Developmental history was grossly normal. However, between age 7 and 8, Jeremiah was exposed to sexual abuse from an older first cousin. This individual has now been convicted and is currently in prison. Jeremiah's mother described him as a historically happy-go-lucky child who has demonstrated marked resilience despite a history of abuse. However, over the past year, he has been spending most of his time in his bedroom watching YouTube. Although he has been attending school, he is failing to meet academic milestones. He has lost 15 pounds over the past month and has stopped showering regularly. Mom says that for the past few months he's been going by a new name, Avenger, and his internet search history revealed the following searches: how to locate hidden listening devices, signs you've been implanted with a microchip by the government, and how politicians read minds and put thoughts in your head. On assessment, he was vitally stable, but he was very hesitant to speak to me. For the most part, he stared at the floor, and when he did speak, he would put his hand to his forehead, shake his head, and laugh. As far as I can tell, there's no history of mental illness, including mood disorder or PTSD, and family history was non-contributory. He does not use substances, as evidenced by toxicology, and takes no medications. Medical workup is benign. Keeping in mind this is a presentation on SSOPD, what is the most likely diagnosis in this case? Jeremiah has schizophrenia. According to DSM-5-TR, schizophrenia is defined as a heterogeneous and impairing clinical syndrome with characteristic symptoms. Several features bear mentioning. Number 1. While functional impairment is required for adults to meet criteria for the diagnosis, children may fail to meet developmental expectations. Number 2. Individuals must have had symptoms for at least 6 months with at least 1 month of active symptoms, that is, delusions or hallucinations. Number 3. If there is a history of autism spectrum disorder or communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month, or less if successfully treated. Following your assessment, you decide to admit Jeremiah under parental consent and contact his parents regarding your preferred diagnosis. They are understandably upset but agree with your treatment plan, including the decision to admit Jeremiah to the inpatient child and adolescent psychiatry unit. They have many questions for you, but given the late hour, the 3 of you agree to discuss things further in the morning. What is the lifetime prevalence of schizophrenia? What is the average age of onset for schizophrenia? Does it differ between males and females? Are there genetic risk factors for this condition? Is it heritable? Are there conception/pregnancy factors that increase the chance of developing schizophrenia? Are there environmental factors that increase the risk of developing schizophrenia? The lifetime prevalence of schizophrenia is somewhere between 0.3 and 0.7%, although many exam prep books cite a value of 1%. The age of onset for this condition is between the late teens to mid-30s in most cases. There are well-characterized sex differences when it comes to schizophrenia. Males tend to have more prominent negative symptoms and longer presentations, which are associated with poorer outcomes. Peak prevalence occurs in the mid-20s, whereas females tend to have more mood symptoms and briefer presentations, which are associated with better outcomes, with peak prevalence in the late 20s. DSM-5-TR includes a number of risk factors for the development of schizophrenia and acknowledges that there is a strong genetic component. But, importantly, most cases do not have a family history of schizophrenia. They note a number of risk factors related to conception, which can be broken down depending on the mother, father, and the baby. Maternal risk factors include stress during pregnancy, infection, malnutrition, and gestational diabetes. Paternal factors include advanced paternal age, and there seems to be a dose-response curve in terms of the age of the father and the likelihood of developing schizophrenia in the offspring. For the baby, risk factors include birth complications, especially those associated with hypoxia. Environmental factors that increase risk of schizophrenia include urban upbringing with an odds ratio of 2, refugee and immigrant status, social oppression and discrimination, and most importantly, adverse childhood events, which convey an odds ratio of 3. The severity of positive and negative symptoms both correlate with the severity of the adverse childhood event experienced by the individual who goes on to develop schizophrenia. KNS notes the risk factor of winter birth, which has an odds ratio of 1.7, and this seems to depend on the latitude, increasing until 50 and then falling down. They also note additional maternal factors, which are listed here. Jeremiah's parents are satisfied with your answers to their questions. Jeremiah's father, a retired pathologist, asks you to describe the differential diagnosis of this condition to prove to him that you really know what you're talking about. What is the differential diagnosis for schizophrenia in general? This is the differential diagnosis for schizophrenia. First, we'll begin by differentiating schizophrenia from major depressive or bipolar disorder with psychotic features or catatonic features. The distinction between schizophrenia and major depressive or bipolar disorder with psychotic features or with catatonia depends on the temporal relationship between the mood disturbance and the psychosis, and on the severity of the depressive or manic symptoms. If delusions or hallucinations occur exclusively during a major depressive or manic episode, the diagnosis is depressive or bipolar disorder with psychotic features. How does schizophrenia differ from schizoaffective disorder? A diagnosis of schizoaffective disorder requires that a major depressive or manic episode occur concurrently with the active phase symptoms and that the mood symptoms be present for a majority of the total duration of the active periods. Now, what about schizophreniform disorder and brief psychotic disorder? These disorders are of shorter duration than schizophrenia, as specified in criterion C, which requires 6 months of symptoms. In schizophreniform disorder, the disturbance is present for less than 6 months, and in brief psychotic disorder, symptoms are present at least 1 day, but less than 1 month. What about delusional disorder? Delusional disorder can be distinguished from schizophrenia by the absence of the other symptoms characteristic of schizophrenia, For example, delusions, prominent auditory or visual hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And what about schizotypal PD? Personality disorders persist, whereas schizophrenia is episodic in nature. And what about OCD and body dysmorphic disorder? Individuals with obsessive compulsive disorder and body dysmorphic disorder may present with poor or absent insight, and the preoccupations may reach delusional proportions. But these disorders are distinguished from schizophrenia by their prominent obsessions, compulsions, preoccupations with appearance or body odor, hoarding, or body-focused repetitive behaviors. And what about PTSD? Post-traumatic stress disorder may include flashbacks that have a hallucinatory quality and hypervigilance that may reach paranoid proportions. But a traumatic event and characteristic symptom features relating to reliving or reacting to the event are required to make the diagnosis of post-traumatic stress disorder. And let's talk more about autism spectrum disorder and communication disorders. These disorders may also have symptoms resembling a psychotic episode, but are distinguished by their respective deficits in social interaction with repetitive and restricted behaviors and other cognitive and communication deficits. An individual with autism spectrum disorder or a communication disorder must have symptoms that meet full criteria for schizophrenia with prominent hallucinations or delusions for at least 1 month in order to be diagnosed with schizophrenia as a comorbid condition. Next, let's consider other mental disorders associated with a psychotic episode. The diagnosis of schizophrenia is made only when the psychotic episode is persistent and not attributable to the physiological effects of a substance or another medical condition. Individuals with a delirium or major minor neurocognitive disorder may present with psychotic symptoms, but these would have a temporal relationship to the onset of cognitive changes consistent with those disorders. And finally, let's talk about the difference between schizophrenia and substance and medication-induced psychotic disorder. Individuals with substance and medication-induced psychotic disorder may present with symptoms characteristic of criterion A for schizophrenia. But the substance and medication-induced psychotic disorder can usually be distinguished by the chronological relationship of substance use to the onset and remission of the psychosis in the absence of substance use. Satisfied that you understand schizophrenia, Jeremiah's father asks you to explain your treatment plan, both in the acute and long term. With safety in mind, how would you proceed with treatment acutely and in the long term for someone presenting with schizophrenia? For comprehensive treatment guidelines related to schizophrenia, please see the 2017 Canadian Schizophrenia Guidelines. Again, here you will note a similar approach to management of psychotic disorders as we have discussed on previous slides. In terms of antipsychotics, these should be initiated at the lower end of dosage ranges and titrated up, continuing on the same medication for 4 weeks, and then if no response, consider switching. We target lower end of the therapeutic effective dose range and decide on antipsychotics based on their side effects. An adequate trial is considered 6 weeks on an adequate therapeutic dose, usually the midpoint or beyond, for that medication. This is also defined as 300 to 400 milligrams of chlorpromazine equivalent, or 4 to 6 milligrams of risperidone equivalent. Both LAIs and oral medications can be offered at the same time, and they can be offered early. In fact, offering an LAI first results in a 6-fold reduction in the risk of relapse after a first episode. Clozapine can be used in the case of treatment resistance, and in the event an individual has a concurrent substance use disorder, both addictions therapy as well as medications for schizophrenia can be initiated at the same time. There's evidence to support CBT for psychosis, as usual for psychoeducation, as well as social support in the form of supported employment, supported housing, peer support, cognitive mediation, social skills training, and life skills training. The comprehensive treatment of schizophrenia is beyond the scope of this presentation, but again, I do recommend you review the 2017 Canadian Schizophrenia Guidelines for more information. Now to finish up case 4. Eventually, Jeremiah is stabilized on medication and is discharged home. He is connected to the early psychosis intervention program and becomes a model client. Case 5. Ashlyn is a 22-year-old non-binary individual referred to you for assessment of psychotic depression. Unfortunately, it is incredibly difficult to engage them in history-taking. They are tearful and demonstrate intense, prolonged eye contact. Their speech is slow and low volume. They perseverate and repeatedly ask you, "What did I do? Why do you want to kill me?" over and over again. They exhibit thought blocking, and their clothing is soiled. Eventually, they stand and move towards you quickly with both hands raised. Thankfully, a security officer intervenes and closes the door to the ICR. You call Ashlyn's mother for collateral and learn that for the past 9 months they have been struggling with symptoms of psychosis and intermittent depressive episodes. At first I noticed they were quite paranoid, wouldn't leave their room, was suspicious of the mail carrier. Then they started telling me that people in the TV were talking to them. It's really strange, and things have only gotten worse since. About 7 months ago they started showing signs of depression, were crying all the time, and really haven't got much better since then. Keeping in mind this is a presentation on SSOPD, what is the most likely diagnosis? Are there any specifiers unique to this diagnosis that you could apply? This is schizoaffective disorder, the essential feature of which is the presence of criterion A for schizophrenia, along with a major mood episode. Anhedonia is not included when considering the presence of a major mood episode because it overlaps with the negative symptoms of psychosis. In order to qualify for a diagnosis of schizoaffective disorder, a major mood episode must be present for at least 50% of the illness. Unique specifiers used in schizoaffective disorder include schizoaffective disorder bipolar type and schizoaffective disorder depressive type, depending on the mood episode encountered. You discuss the presumed diagnosis with Ashlyn's mother and admit them under certification. You reviewed the case with the psychiatric nurse working with you in the emergency department, who asks you the following questions about schizoaffective disorder. What is the lifetime prevalence of schizoaffective disorder? What is the average age of onset for schizoaffective disorder? Is there any difference between males and females when it comes to schizoaffective disorder? How does the prognosis of this condition compare to that of schizophrenia and bipolar disorder? Are there any biological risk factors? The lifetime prevalence of schizoaffective disorder is 0.32%, and average onset occurs in early adulthood. The rate of bipolar subtype is equivalent between the sexes, but the female-to-male ratio for depressive subtype is 2:1. Generally speaking, the outcome of schizoaffective disorder is poorer than mood disorders, but better than schizophrenia. According to DSM-5-TR and KNS, there does appear to be some genetic overlap between schizoaffective disorder, schizophrenia, and bipolar disorder. "Oh, I see," says your nursing colleague. "And how can you differentiate between schizoaffective disorder and other psychotic disorders, or other mental disorders?" What is the differential diagnosis for schizoaffective disorder in general? This is the differential diagnosis for schizoaffective disorder. First, let's talk about other mental disorders and medical conditions. A wide variety of psychiatric and medical conditions can manifest with psychotic and mood symptoms and must be considered in the differential diagnosis of schizoaffective disorder. These include delirium, major neurocognitive disorder, substance and medication-induced psychotic disorder or neurocognitive disorder, bipolar disorders with psychotic features, major depressive disorder with psychotic features, depressive or bipolar disorders with catatonic features, schizotypal, schizoid, or paranoid personality disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, delusional disorder, and other specified and unspecified schizophrenia spectrum and other psychotic disorders. Schizoaffective disorder must also be differentiated from the psychotic disorder due to another medical condition. Other medical conditions and substance use can manifest with a combination of psychotic and mood symptoms, and thus psychotic disorder due to another medical condition needs to be excluded. Finally, how do we distinguish between schizoaffective disorder, schizophrenia, bipolar disorders, and depressive disorders? If we examine the criteria, we will see that criterion C distinguishes schizoaffective disorder from schizophrenia, and criterion B distinguishes schizoaffective disorder from depressive or bipolar disorders with psychotic features. Distinguishing schizoaffective disorder from schizophrenia and from depressive and bipolar disorders with psychotic features is often difficult. Criterion C is designed to separate schizoaffective disorder from schizophrenia, and criterion B is designed to distinguish schizoaffective disorder from a depressive or bipolar disorder with psychotic features. More specifically, schizoaffective disorder can be distinguished from a major depressive or bipolar disorder with psychotic features based on the presence of prominent delusions and or hallucinations for at least 2 weeks in the absence of a major mood episode. In contrast, in depressive or bipolar disorder with psychotic features, the psychotic features only occur during the mood episodes. Because a relative proportion of mood to psychotic symptoms may change over time, the appropriate diagnosis may change from and to schizoaffective disorder. For example, a diagnosis of schizoaffective disorder for a severe and prominent major depressive episode lasting 4 months during the first 6 months of a chronic psychotic illness will be changed to schizophrenia if active psychotic or prominent residual symptoms persist over several years without recurrence of another mood episode. Achieving greater clarity about the relative proportion of mood to psychotic symptoms over time and about their concurrence may require collateral information from medical records and from informants. Obviously, I have a lot to learn about schizoaffective disorder. Thanks for clarifying that. The nurse goes on to ask you questions about your plans for treatment moving forward. With safety in mind, how would you proceed with treatment acutely and in the long term for someone presenting with schizoaffective disorder? The treatment of schizoaffective disorder typically involves both pharmacotherapy and psychotherapy. The mainstay of most treatment regimens should include an antipsychotic, but the choice of treatment should be tailored to the individual. A study that reported data obtained on treatment regimens for schizoaffective disorder showed that 93% of patients received an antipsychotic. 20% of patients received a mood stabilizer in addition to an antipsychotic, while 90% received an antidepressant along with an antipsychotic. Prior to initiating treatment, if a patient with schizoaffective disorder is a danger to themselves or others, inpatient hospitalization should be considered. This includes patients who are neglecting activities of daily living or those who are disabled well below their baseline in terms of functioning. What makes the most sense to me in treating patients with schizoaffective disorder is to treat them with guidelines for bipolar 1, depending on the mood episode you see before you, with an antipsychotic that is indicated in that disorder. In the event that the patient requires rapid treatment or has another indication for ECT, ECT should be selected as a treatment of choice. And now to conclude Case 5. Ashland's condition proves very difficult to treat and eventually decide to proceed with ECT. Thankfully, mood symptoms remit following their index course, and he discharged them on a community treatment order mandating that they attend regular follow-up with their care team and adhere to all prescribed treatments. Insight remains poor at discharge, but you are hopeful that connection to a community mental health nurse and the presence of supportive family will improve their long-term prognosis. And now Case 6. It's been 2 years since you completed emergency medicine residency and accepted a full-time position at the city hospital, and tonight you're stuck working a particularly boring night shift. Feeling tired, you make your way to the emergency department lounge for a cup of tea and a cat nap. You kick your feet up on the coffee table and make your way to dreamland. In a dream, you are transported to a bustling emergency department in downtown New York City. The year is 1934. A nurse approaches you with the following patient history. Mr. Menninger is a 35-year-old lawyer, the oldest of a family of 5 children born to healthy parents. He finished his pre-law work with some difficulty, since it was necessary for him to work, and graduated in law from an Eastern university with a good scholastic record. During his first year of apprenticeship, he became involved with a girl who became pregnant. He developed a depression which lasted several months. 3 years later, at the age of 28, he developed a second minor depression, again following a disappointment in love. At the age of 31, he married, though was unhappy with his wife over minor questions of morality. 2 years after the marriage, she died in childbirth. 1 month ago, he attempted suicide by carbon monoxide poisoning and attended our department after he was found unconscious in front of his fireplace mantel. Today, he presented with several behavioral and mental symptoms, including social withdrawal, abulia, and speaking in short phrases. For example, "This is torture." Treatments attempted thus far include administration of phenobarbital, which has produced minimal effect. Keeping in mind this is a presentation on SSOPD, what is the most likely diagnosis in this case? This is substance or medication-induced psychotic disorder, the essential feature of which is prominent delusions and/or hallucinations due to physiological effects of a substance or medication. The most important criteria is that the delusions or hallucinations came during or shortly after withdrawal or intoxication with a substance or exposure to medication that can cause delusions or hallucinations. Hallucinations that the individual realizes are substance medication induced are not included here and instead would be diagnosed as substance intoxication or substance withdrawal with the accompanying specifier with perceptual disturbances. There are two specifiers which bear mentioning here. The first is with onset during intoxication. In this situation, criteria are met for intoxication with the substance, and symptoms develop during intoxication. The other is with onset during withdrawal. In that situation, criteria are met for withdrawal from the substance, and symptoms develop during or shortly after withdrawal. Startled, you awake to the sound of your colleague entering the emergency department lounge. You soon find yourself relaying your dream to them, their interest piqued and eyebrow raised. It sounds like you ought to lay off the coffee this late at night. Maybe you're suffering from a substance medication-induced psychotic disorder too. They chuckle as you stretch and get ready to return to work. What is the prevalence of substance and medication-induced psychotic disorder? What percentage of first episode psychosis is accounted for by this disorder? What percentage of individuals with this disorder go on to develop schizophrenia? According to DSM-5-TR, the prevalence of substance and medication-induced psychotic disorder is unknown. However, KNS quotes a lifetime prevalence of 0.59%. Substance and medication-induced psychotic disorder accounts for between 7 and 25% of first episodes of psychosis, and of these cases, 26% eventually develop into schizophrenia spectrum disorder, such as schizophreniform disorder, schizophrenia, or schizoaffective disorder, whereas 8% go on to develop bipolar disorder. In one study, 10% of patients who presented with symptoms of psychosis and substance use disorders met criteria for substance and medication-induced psychotic disorder, and 25% of these individuals progressed to schizophrenia spectrum disorder within 20 years. The table on the right side of this slide outlines substances, medications, and toxins associated with this diagnosis. Neither DSM-5-TR or KNS specify risk factors for this disorder, but is likely a combination of risk factors for substance use disorders and for primary psychotic disorders. Back in the emergency department, the local police have just brought in a 20-year-old man who appears quite agitated and is apparently intoxicated. On review of his electronic health record, you see that he has a history of crystal methamphetamine use disorder and is presented to the ED with, quote, psychosis, end quote, on at least 5 occasions in the past 3 years. You sign up for this patient, but not before popping by the psychiatric nurse's desk and asking them to give you a differential diagnosis for substance and medication-induced psychotic disorder. What is the differential diagnosis for substance and medication-induced psychotic disorder in general? This is the differential diagnosis for substance and medication-induced psychotic disorder. First, let's consider substance intoxication or substance withdrawal. Individuals intoxicated with stimulants, cannabis, the opioid midpyridine or phenylcyclidine, or those withdrawing from alcohol or sedatives may experience altered perceptions that they recognize as drug effects. If reality testing for these experiences remains intact, that is, the individual recognizes that the perception is substance-induced and neither believes in nor acts on it, the diagnosis is not substance or medication-induced psychotic disorder. Instead, substance intoxication or substance withdrawal with perceptual disturbances is diagnosed. For example, cocaine intoxication with perceptual disturbances. Flashback hallucinations that occur long after the use of hallucinogens have stopped are diagnosed as hallucinogen persisting perception disorder. If substance or medication-induced psychotic symptoms occur exclusively during the course of a delirium, as in severe forms of alcohol withdrawal, the psychotic symptoms are considered to be an associated feature of the delirium and are not diagnosed separately. Delusions in the context of a major or mild neurocognitive disorder will be diagnosed as major or mild neurocognitive disorder with behavioral disturbance. Next, let's differentiate between substance medication-induced psychotic disorder and an independent psychotic disorder. A substance and medication-induced psychotic disorder is distinguished from an independent psychotic disorder, such as schizophrenia, by the fact that a substance is judged to be etiologically related to the symptoms. How does substance and medication-induced psychotic disorder differ from psychotic disorder due to another medical condition? A substance or medication-induced psychotic disorder due to a prescribed treatment for a mental disorder or medical condition must have its onset while the individual is receiving the medication, or during withdrawal if there is withdrawal syndrome associated with that medication. Because individuals with medical conditions often take medications for those conditions, the clinician must consider the possibility that the psychotic symptoms are caused by the physiological consequences of the medical condition itself, rather than the medication, in which case psychotic disorder due to another medical condition is diagnosed. The history often provides a primary basis for such a judgment. At times, a change in the treatment for the medical condition, for example, medication substitution or discontinuation, may be needed to determine empirically for that individual whether the medication is the causative agent. If the clinician has ascertained that the disturbance is attributable to both a medical condition and substance or medication use, both diagnoses, that is, psychotic disorder due to another medical condition and substance and medication-induced psychotic disorder, may be given. And now let's differentiate substance and medication-induced psychotic disorder from other specified or unspecified schizophrenia spectrum and other psychotic disorders. The psychotic symptoms included in the diagnosis of substance and medication-induced psychotic disorder are limited to either delusions or hallucinations. Individuals with other substance-induced psychotic symptoms, for example, disorganized or catatonic behavior, disorganized speech, incoherence or irrational content, should be classified in the category of other specified or unspecified schizophrenia spectrum and other psychotic disorder. The patient is unintelligible and aggressive, and you decide to let him come down before initiating a treatment plan. Unfortunately, he begins banging his head against the ICR door and yelling loudly. Your nurse colleague asks you how you would like to proceed. With safety in mind, how would you like to proceed in the treatment acutely and in the long term for someone presenting with substance and medication-induced psychotic disorder? The acute treatment of substance and medication-induced psychotic disorder is not entirely different than what we've seen in other psychotic disorders thus far. Obviously, safety is a priority and is based on our assessment of suicidal and homicidal ideation, as well as the patient's level of function. Where treatment in the long term differs is the need to discontinue substance use and provide treatment for the underlying substance use disorder. Pharmacotherapy may include antipsychotics for management of active symptoms, agitation, and aggression, as well as the use of benzodiazepines for management of anxious symptoms and agitation, as well as alcohol withdrawal. In conclusion, the patient soon responds to your acute treatment plan and sleeps for the remainder of your shift. In the morning, you hand them over to your colleague and head home to sleep. Maybe you'll get a chance to finish your dream. At last you heard the patient remained actively psychotic despite having been on medication. You're pretty certain this is a diagnosis of substance and medication-induced psychotic disorder. Now case 7. 41-year-old Mrs. W. was brought to hospital by EMS after she began to experience auditory command hallucinations instructing her to cut her wrists. Mrs. W. tells you that the voices belong to a group of dead aliens who are punishing her for not writing coded messages to the Prime Minister which could have saved the lives of the aliens. In addition to symptoms of psychosis, she also reports acute abdominal colic, vomiting, fever, headache, and a racing heart rate. Your physical examination is notable for ascending paralysis and elevated blood pressure. Laboratory tests are significant for leukocytosis. Interestingly, whilst helping Mrs. W. to the washroom, one of the nurses noticed that her urine had a reddish-purple color, which darkened following prolonged exposure to light. Keeping in mind this is a presentation on SSOPD, what is the most likely diagnosis in this case? And as a bonus question, what general medical condition is afflicting Mrs. W.? This is a case of psychotic disorder due to another medical condition, the essential feature of which is prominent delusions or hallucinations due to the physiological effects of a general medical condition. Two unique specifiers apply to this diagnosis. These are with delusions, which applies if delusions are the predominant symptom, and with hallucinations, if hallucinations are the predominant symptom. You contact Mrs. W's sister, with whom she has been living, and review the presumed diagnosis. You inform her of the genetic risk for this condition and the need to review this concern with her family physician. She has several questions for you related to the epidemiology of your preferred diagnosis. What is the lifetime prevalence of psychotic disorder due to another medical condition? What are the most common types of medical conditions related to this disorder? What are the conditions most likely to cause this condition in early life? What about in late life? According to DSM-5-TR, the lifetime prevalence of psychotic disorder due to another medical condition is between 0.21 and 0.54%. This increases after the age of 65, with a lifetime prevalence of 0.74%. According to KNS, the estimated lifetime prevalence is 0.76. Risk factors for psychotic disorder due to another medical condition include untreated general medical conditions that can cause psychosis. The most common types of medical conditions that can cause psychotic disorder due to another medical condition include endocrine and metabolic disorders, autoimmune disorders, NMDA receptor encephalitis, and temporal lobe epilepsy. In early life, the three most common causes are epilepsy, head trauma, and autoimmune diseases. Whereas in late life, the three most common causes of this diagnosis are stroke, anoxic events, and cardiac events. Mrs. W's sister asks you, how can you be so sure? Couldn't something else be causing this condition? What is the differential diagnosis for psychotic disorder due to another medical condition? Just want to clarify here that I'm not asking for what other medical conditions could have caused this condition. This is the differential diagnosis for psychotic disorder due to another medical condition. First, let's differentiate psychotic disorder due to another medical condition from delirium and major or mild neurocognitive disorder. Hallucinations and delusions commonly occur in the context of a delirium. A separate diagnosis of psychotic disorder due to another medical condition is not given if the delusions and/or hallucinations occur exclusively during the course of a delirium. On the other hand, a diagnosis of psychotic disorder due to another medical condition may be given in addition to a diagnosis of major or mild neurocognitive disorder if the delusions or hallucinations are judged to be a physiological consequence of the pathological process causing the neurocognitive disorder, such as in the case of psychotic disorder due to Lewy body disease with delusions. How does psychotic disorder due to another medical condition compare to substance and medication-induced psychotic disorder? According to DSM-5-TR, if there is evidence of recent or prolonged substance use, including medications with psychoactive effects, withdrawal from a substance or medication that can cause psychotic symptoms on withdrawal, or exposure to a toxin, such as LSD, intoxication, or alcohol withdrawal, a substance and medication-induced psychotic disorder should be considered. Symptoms that occur during or shortly after, that is within 4 weeks, of substance intoxication or withdrawal, or after medication use may be especially indicative of a substance and medication-induced psychotic disorder, depending on the character, duration, or amount of the substance used. If the clinician has ascertained that the disturbance is due to both a medical condition and substance use, both diagnoses, that is, psychotic disorder due to another medical condition, and substance and medication-induced psychotic disorder can be given. How does psychotic disorder due to another medical condition differ from other psychotic disorders? Psychotic disorder due to another medical condition must be distinguished from a psychotic disorder that is not due to another medical condition, such as schizophrenia, delusional disorder, or schizoaffective disorder, or a major depressive or bipolar disorder with psychotic features. In psychotic disorders and in depressive or bipolar disorders with psychotic features, no specific and direct causative physiological mechanism associated with a medical condition can be demonstrated. Late age at onset and the absence of a personal or family history of schizophrenia or delusional disorder suggests the need for a thorough assessment to rule out the diagnosis of psychotic disorder due to another medical condition. Auditory hallucinations that involve voices speaking in complex sentences are more characteristic of schizophrenia than of psychotic disorder due to a medical condition. Clinicians should not give undue weight to any one particular hallucination alone when deciding between a psychiatric and a medical cause for psychopathology. Whilst Mrs. W's sister is reassured that her sister probably doesn't have schizophrenia or another psychotic disorder, she's anxious to know how you plan to proceed with treatment. With safety in mind, how would you proceed with treatment acutely and in the long term for someone presenting with psychotic disorder due to another medical condition? Is there anything you need to tell Mrs. W's sister regarding Mrs. W's prognosis? Treatment for psychotic episodes of this nature are based on treatment of the underlying condition. Often treating the primary medical condition results in a remission of psychotic symptoms, but sometimes psychosis continues long after the medical issue has been resolved, and further treatment is required for residual symptoms that affect daily activities and social relationships. Antipsychotic medications may be prescribed to help control delusions and hallucinations and prevent the reoccurrence of symptoms. The prognosis depends on the ability to manage the underlying medical condition, which can be quite difficult. Now to conclude, Mrs. W is admitted to the internal medicine unit with plans to be followed by the consultant liaison psychiatry team. She is treated with Hematin, 4 mg per kilogram per day, for 4 days, and her sister undergoes genetic testing to interrogate the diagnosis of acute intermittent porphyria. While there is some improvement with regards to Mrs. W's psychotic symptoms, she never returns to baseline and eventually dies of a stroke at 52 years of age. Now to conclude with cases 8 and 9. You are a PGY2 psychiatry resident on call, and it is one of the worst call shifts you've ever had. The medical student scheduled to work with you is sick with COVID-19. The PGY1 scheduled to work with you is sick with COVID-19. And the PGY5 resident, the junior attending, is also sick with COVID-19. Thankfully, the staff psychiatrist working with you has come in to help with a record number of consults, all of which are legitimate. You are finding it hard to keep up, and your staff is plodding along one finger at a time as they struggle to complete their documentation. Somehow, you manage to complete 2 consults in record time. Both patients were referred for assessment of hallucinations, although one is seated in the waiting room and the other has been placed in an ICR. Unfortunately, neither of them has an updated emergency contact number associated with their health record, so you're unable to gather collateral information. First, case 8. This patient is seated calmly in the waiting room. You've asked to speak with them and they shush you. Sorry, doc, it's hard to focus when all of you are talking. On history taking, you learn that they have been experiencing persistent auditory hallucinations for the past 4 years with no obvious trigger. It's really starting to get in the way of work, doc, but I really don't mind them. Review of symptoms is otherwise benign. And case 9. This patient is unable to engage in conversation as he is actively communicating with an unseen individual and shushes you when you try to interrupt, and waves you back out of the ICR. As you retreat back to your office, you can hear him saying, "It's been 21 days and still no one realizes how powerful you are." What is your preferred diagnosis for case 8? What is your preferred diagnosis for case 9? Keeping in mind that there can be multiple correct answers here. Case 8 was designed to highlight the features of other specified schizophrenia spectrum and other psychotic disorder. Here there are symptoms of an SSOPD that lead to dysfunction, and the clinician chooses to communicate specific reasons why the presentation does not meet the criteria for any specific schizophrenia spectrum and other psychotic disorder. In Case 8, a diagnosis could be other specified schizophrenia spectrum and other psychotic disorder, persistent auditory hallucinations. Case 9 was designed to characterize unspecified schizophrenia spectrum and other psychotic disorder, which is essentially the same diagnosis, except the clinician chooses not to specify the reason that the criteria are not met for a specific schizophrenia spectrum and other psychotic disorder, and includes presentations in which there is insufficient information to make a more specific diagnosis, such as in the emergency department. This is the end of our presentation. By now I hope you'll be able to recall the essential features of delusional disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, substance and medication-induced psychotic disorder due to another medical condition, and other specified and unspecified schizophrenia spectrum and other psychotic disorders. I hope you'll be able to comment on the epidemiology and risk factors for each of these disorders, be able to create a 3 to 4 item differential diagnosis for each of these disorders, and name some of the common treatments used in management of these disorders. This slide is a quick overview of the diagnoses we've covered, as well as their essential features. The essential feature of delusional disorder is the presence of one or more delusions that persists for at least 1 month. The essential feature of brief psychotic disorder is a disturbance with at least one positive symptom or grossly abnormal psychomotor behavior or catatonia for less than 1 month. The essential feature of schizophreniform disorder is at least one of delusions, hallucinations, or speech disturbance, in addition to at least one more psychotic symptom for less than 6 months. The essential feature of schizophrenia is identical to that of schizophreniform disorder, except that the total symptomatic period lasts longer than 6 months. The essential feature of schizoaffective disorder includes the similar criteria as schizophreniform disorder and schizophrenia, except that a major mood episode must be present for at least 50% of the illness course. The essential feature of substance and medication-induced psychotic disorder includes either delusions and/or hallucinations as a consequence of a substance or medication. The essential feature of psychotic disorder due to another medical condition is the presence of delusions and/or hallucinations as a consequence of a general medical condition. The essential feature of other specified is symptoms of schizophrenia spectrum or other psychotic disorder which leads to dysfunction, and you choose to say why it doesn't meet criteria for another diagnosis. In contrast, the essential feature of unspecified is a situation in which you choose not to say why that diagnosis does not meet criteria for any other disorder in the schizophrenia spectrum or other psychotic disorders chapter. This slide is a brief overview of general treatment principles, which include determining the site of treatment based on safety assessment, the use of pharmacotherapy in terms of antipsychotics, benzodiazepines, mood stabilizers, and antidepressants, the use of psychotherapy, including psychoeducation, supportive psychotherapy, and CBT for psychosis, as well as a focus on community and rehabilitation. This concludes my presentation. Thank you all for your attention.